So let's talk about relapsed myeloma. In the old days, we used to wait till people were exhibiting symptoms before we treated them. I sense there's been a move to intervene more quickly because we have new drugs to use. You nodding, Ed, you agree with that? Numbers are going up. Do you wait, or do you just get in there and start?
Well, I think that's the key to the whole discussion, is that in the old days, we didn't have as good tests.
By the way, we were all part of those.
Yeah, I know. Yeah. I'm part of the old days.
Speak for yourself.
We didn't have great tests to monitor patients, and so we had to wait for them to have a broken bone or bad anemia. Now, with the light chain analyses, with our serum protein electrophoresis sensitivities, and our close monitoring of patients, we will detect most of the patients before some catastrophic event that their disease is progressing. My first intervention tends to be to watch them more closely rather than to initiate any therapy if it's just a number that's going up. And then we start trying to get the tempo. And but a lot of it depends on how sick the patient was when they were initially presenting. Because if their disease was really nasty, I don't want to watch someone go into renal failure. I don't want to watch someone have worsening neuropathy. And so it's a very patient-specific sort of approach.
My caveat to that would be that if we know that they had high-risk disease at the beginning, I'm less comfortable watching those patients. Right. And two, I'm doing more PET scans at the time of biochemical relapse, because that's where you find out stuff that you didn't anticipate.
I must say I've been disinclined to watch and wait anymore when I've almost had this sense that if you had CyBorD and a transplant and 18 months of lenalidomide maintenance, you're undertreated, and we should start again from scratch and try and get you back into MRD negativity. But maybe that's just me, I don't know. So let's assume we've done what we said we would do in the last session. You've had RVD, you've had a transplant, some consolidation, lenalidomide maintenance, and you're now progressing. I'd kind of like to hear from the group, understanding there's no one-size-fits-all regimen, what kind of regimens you're using at first relapse. And maybe we'll go this way. Tom, you can tell us.
So I think 3 of the studies, in the 1 to 3 prior lines of therapy, the daratumumab bortezomib index, so DVD, daratumumab lenalidomide index, DRD, and in your study, the carfilzomib lenalidomide index, KRD, both have shown, or all 3 of them have shown, significant advantage to starting one of those 3 regimens in people that have first relapse. So like you were just saying, I try to be pretty aggressive in the first relapse, especially in the young patients, especially in patients that can tolerate really aggressive therapy from the start. So I will usually give them KRD, DRD, or DVD at the time of first progression. If they're truly lenalidomide refractory, then probably I'm going to do DVD as the regimen. But
you wouldn't switch to pomalidomide instead of lenalidomide?
I think it depends. So for some people, if their counts are not a problem, I will do DPD. Often I'll actually not do it as the second regimen. I save pomalidomide for the next regimen. So.
Okay. AJ, what do you think? Do you class switch, or do you just give the next generation of the same drugs?
I think if you're going to practice from evidence-based medicine, if you include the 4 len-based backbone and the 3 bortezomib, you really have 7 studies to choose from. But the reality is, how many of those patients are actually applicable to who's sitting in front of you in clinic, which is progressing on len maintenance? Because then you essentially exclude those 4 studies that required len naive. Right. And then you end up with the 3 VD backbone regimens. But I think DARA has shown in this first relapse consistently to have a better reduction in the risk of progression relative to the control arm. So I would favor DARA-based regimen, and then the partner drug depends on the patient. So DARA with POM, if they have no history of thrombotic events, good blood counts. If they're 414, maybe either DKD or with carfilzomib or with bortezomib. I think luckily we have so many combination abilities to pick from.
Right. I suspect we're going to hear the same from all of you. Is that pretty much consistent with your approach?
Yeah, I mean, I think Ajai presented some interesting data with the DARA KD in terms of using carfilzomib weekly and then splitting the dose of DARA, so making it a little bit more user-friendly, because that used to be a little bit of a roadblock to putting patients on that choice.
So carfilzomib a bit more attractive. I think we're going to probably talk about that study in a minute.
So I
Sagar?
think what's really interesting is that the efficacy of POM in both 414 as a partner and in 17P is probably undervalued. In 17P, it actually looks as good as any other drug that's out there. So Dara-Pom-Dex, for that reason, is sort of our go-to in the first salvage. And I've been really struck by the 414s and how well they've responded after having short responses to either K or V.